Welcome all to the class. So we begin with vulval cancer, screening and follow-up in vulval carcinoma. We begin with our quote, Master MRCOG with concept-oriented clarity. These are British Gynecological Cancer Society guidelines published in May 15th May 2020. So what about the screening for cancer in vulva? There is no proven screening test which exists for vulval carcinoma, but there are high-risk groups. These are patients with vulval intraepithelial neoplasia or patients with lichen planus or lichen sclerosis. In the last lecture, we have seen that lichen planus, lichen sclerosis, they have got a high chance of or high risk of development of squamous cell carcinoma. Okay, VIN also has got a risk of development of the squamous cell. This is a pre-malignant condition. Okay, so do you remember the chance of development of carcinoma in LS or LP? What is the chance, and what is the chance in usual VIN?
LP is around 6%.
Yeah, 2.2 to 6.6%, and it is less with the usual VIN, which is a HPV associated. Okay, see here they have given risk of progression. When you have a usual VI, there is a 5.7% risk of progression to carcinoma over a period of 14 years. When you have a LS and LP, that is lichen sclerosis or lichen planus, there is a risk of 2.6 to 6.6%. It's a lifetime risk. And differentiated VI, that means it is LSLP superimposed this VIN, that is a differentiated type of VIN. It has got a very high progression risk and it should be surgically excised. Okay, so this VIN, first thing, this LS and LP is a benign condition. It's a chronic inflammatory condition. Okay, but it can lead to VIN. It can lead to especially differential VIN, and this has got a high chance of conversion to the malignancy, and we have to excise it. The relative risk of differential VIN is 38.5, and for usual VIN is 0.065. Follow-up for lichen sclerosis and lichen planus. What is the follow-up? So initial review should be done at 3 months, then 6 months, and then annual review. Once the disease becomes stable, then the annual review. So that is what we have seen in the treatment of lichen sclerosis and lichen planus. Treatment is same. The clobetasol, propionate, 0.05%, ointment. Okay, how it is to be applied? It is to be applied for 3 months, daily, then alternate day, and then twice a week. Okay, each month, and 30-gram tube over a period of 3 months it should last. Okay, and high cure rate is seen. Then what is the patient advice? Patient should report for new or symptomatic lesions immediately. The risk of cancer with suspicious lesion is 13%, and it requires urgent referral under cancer wait time pathway. So you have to refer urgently this patient when you have a suspicious lesion. Okay, so patient may be just symptomatic without lesion, and patient may be symptomatic with lesion. If there is a lesion, there is a 13% chance that the lesion can be malignant. Okay, so when you see the lesion, then we are more worried. Okay, so what is the follow-up for VIN? For usual VIN, follow-up is with formal vulvoscopy. For multifocal disease, higher recurrence risk, and ensure cervical screening and assess for anal and perianal neoplasia also. Okay, and the frequency should be 6 monthly for 2 years, and then annual follow-up for 5 years is required. Okay, so what previously we have seen the follow-up for the lichen sclerosis and lichen planus, and this is the follow-up for VIN. Okay, 6 monthly for 2 years, then annual follow-up for next 5 years. Okay, unifocal treated disease, you can discharge the patient after 5 years, but if the disease is multifocal or recurrent disease, then it requires a long-term follow-up. Okay, so HIV and anal cancer screening, especially when HIV testing is recommended for a multifocal HPV related disease. So when you have a usual VIN which is HPV induced, and if it is a multifocal, this you have to screen for other things. Okay, especially one is HIV, and second, anal screening, anoscopy, cytology, that you have to do. So not routinely recommended for women with usual VIN or vulval cancer. Digital rectal examination advised if anal symptoms are plain pain and bleeding is there. So this you will advise if there is a pain or bleeding. Okay, so but HIV testing is mandatory. Okay, and anoscopy and all when there are symptoms such as bleeding and pain. Now, what is the role of HPV vaccination? It reduces the future usual VIN and HPV related vulval squamous cell carcinoma. is there a role of imiquimod, cidofovir, and surgical excision? The treatment, we know that VIN, we go for surgical excision. So options for high grade VIN, but whatever, generally there is a 50% response. Okay, and recurrence at 12 months is high. Cidofovir is unlicensed for the treatment of VIN. Then topical or ultra potent steroids for lichen sclerosis and lichen planus, it improves the symptoms and it also reduces the risk of development of the squamous cell carcinoma. Then what is the routine screening test for vulval cancer? There is no proven test as such for the screening for the vulval cancer. Follow-up for multifocal disease, it is a long-term follow-up and you have to do the colposcopy, digital anorectal examination and refer if there are anal symptoms. Okay. Then HIV testing is recommended for multifocal HPV disease. Follow-up for high-grade usual VIN is careful inspection and maybe a vulvoscopy you can add. Lichen sclerosis, lichen planus follow-up, we have seen that initially you have to follow up 3 months, and once the disease becomes stable, then it will be annual primary care review. Okay. Then new non-responsive lichen sclerosis lesion, these will require a referral via cancer weight pathway if there is no improvement after 1 to 2 weeks of potent steroid. So 1 to 2 weeks of potent steroid, if there is no response, you will refer these patients via cancer weight pathway. Okay. Now, this there are two important flowcharts. Please concentrate on this particular flowchart. First flowchart is about the vulval lesion. What we have seen in the beginning, the patient can have a symptoms, but there is no vulval lesion. If there is a vulval lesion, there is a high chance, 13% chance of having some malignancy, and that is why biopsy is going to be very important in that particular case. And the second is about if the biopsy shows vulval squamous cell carcinoma, how to follow. So there are two charts. One, when there is a lesion, and second, when you take a biopsy and it turns out to be vulval squamous cell carcinoma, what is the follow-up? So these two particular flow charts you please remember. So first lesion we will see. There is a vulval lesion. It may have symptoms such as pain, bleeding, etc. Then what we have to decide first, what is the clinical suspicion? Is it a high chance of suspicion of malignancy, or whether there is a low chance of suspicion of malignancy? Okay, now let's focus on this. If there is a clinically low chance of suspicion of the malignancy and totally benign lesion, you just reassure and discharge with symptomatic care to the primary care. Okay, so you will discharge that particular if it is a clinically benign case. Okay, then other chances, it can be just lichen sclerosis or lichen planus, or it can be clinically VIN. So these two cases are, though they are non-malignant, but there is a potential for the development of the malignancy. So these patients will require a workup. Okay, lichen sclerosis, lichen planus, and if it is a clinically VIN. Okay, it may be differentiated VIN or it may be usual VIN, which is a HPV induced, and differentiated is secondary to the LS and LP. Now, this, if you suspect a VIN, directly you go for punch biopsy or wedge biopsy. In the this particular options, if you have an incisional biopsy, you can select that also. Okay, but excision biopsy is not recommended. Remember, when we have studied about the cervix, we were discussing about the excision biopsy. Here, excision biopsy is not recommended. You can go for punch or wedge biopsy, including the lesion margin. Okay, so it has to have a margin. So the biopsy should not be taken from the center of the lesion. It should be taken from the margin of the, and it should be representative of normal and abnormal area. Then you should need to have a photograph or draw a diagram indicating the biopsy site, and do not perform the excision biopsy without histology, as it may rule out the option for sentinel lymph node biopsy if the cancer is diagnosed. That is why they do not recommend excision biopsy. And SBA is most of the time here. What type of biopsy you will take? It may be punch, wedge, or incisional biopsy, but you will not take the excision biopsy here. Okay. Then if you have a clinically LS and LP, what is the follow-up? You will have the photograph for the latter comparison. You will treat with the highly potent, ultra potent topical steroids. If there is no improvement within 2 weeks, with adequate treatment, you will send this patient referral again for the biopsy and all. Okay, so these patients, if there is LS and LP, ultra potent steroids. Okay, within 2 weeks there has to be symptomatic relief. If there is no relief, then you will go for this particular thing. and this is when you have a lesion. Now, if there is a possibility, high suspicion of lesion, you will directly go for punch biopsy. You will directly go for wedge biopsy. Okay, so a wedge biopsy, you will also have the photograph or the diagram which will indicate the biopsy site, and refer to gynec oncology team. Do not perform excision biopsy or wait for the biopsy result. You will refer these patients to the oncology team. Okay, so you will take the biopsy and then refer to the, you even need not wait for the report, but you have to refer these patients. Okay, now second is a flow chart in which there is a, you have already taken the biopsy and the biopsy shows vulvar squamous cell carcinoma. Now, if it is a vulvar squamous cell carcinoma, the most important is the depth of invasion. Okay, because the treatment depends upon the depth of invasion. If the depth of invasion is less than 1 millimeter, then you go for excision. Okay, a wide local excision with photographs or diagram indicating biopsy site. Sentinel lymph node biopsy is not required. Please remember, in less than 1 millimeter, lymphadenectomy or sentinel lymph node biopsy is not required. It is just a local disease. So wide local excision, this is frequently asked. They will give you the scenario, they will give you the biopsy report, and you just have to note it down. What is the size of the lesion and what is the depth of invasion? Okay, so when the depth of invasion is less than 1 millimeter, we'll see later on in the staging. Okay, this is in the stage 1A. Okay, stage 1B is more than 1 millimeter invasion. Stage 1A is less than 1 millimeter depth of invasion. So you will go for wide local excision. You will have photographs or the diagram which will indicate the biopsy site, and lymphadenectomy or sentinel lymph node biopsy is not required. However, if you have a depth of invasion which is more than 1 millimeter, then definitely you have to assess the lymph node. Okay, once there is an invasion, you need to think about the lymph node. So you will do the imaging technique for the inguinal lymph node, such as CT scan. It may be ultrasound also, it may be X-ray also. Okay, you will do the imaging, and you also look for the size of the lesion. Okay, so if the lesion is less than 4 centimeter and no suspicious nodes on the scan, you have done the imaging, there are no suspicious, but the lesion is less than 4 centimeter, then you will go for sentinel lymph node biopsy. Okay, and this sentinel lymph node biopsy you will perform unilaterally if the lesion is lateral, or if it is a you will do the sentinel lymph node biopsy if it is a bilateral, if within 1 centimeter of the midline. So if you, this is the vulva, and if it is within the 1 centimeter of the midline, then there is a crossing of the lymphatics. Okay, so you have to do bilateral. Even if the lesion is on one side, but within 1 centimeter of the midline, you will do the sentinel lymph node biopsy on both sides. But if the lesion is lateral, that is beyond the 1 centimeter, okay, the lesion size is less than 4 centimeter, the lesion is away from the more than 1 centimeter from the midline, but depth of invasion is more than 1 millimeter, then you will do unilateral lymph node biopsy, sentinel lymph node biopsy. Okay, but if the lesion is within 1 centimeter of the midline, you will do bilateral sentinel lymph node biopsy. Is it clear to you, doctor?
Yes, sir.
Yeah. Okay, now you have another situation. You have depth of invasion more than 1 millimeter, but the primary lesion is more than 4 centimeter, equal to or 4. They will give you exact 4 centimeter. I'll tell you, they'll give exact, and this, then you have to follow this particular flow chart. Okay, because the primary lesion is more than 4 centimeter, you will always go for lymphadenectomy. Or if it is a multifocal disease or suspicion of lymph nodes on the scan, then you will go inguinal lymph node dissection. Okay, here you are doing sentinel lymph node biopsy when there are no nodes. There are two things: the lesion should be less than 4 centimeter and there should be no nodes. Here the lesion is either more than 4 centimeter, or there are lymph nodes, or the disease is multifocal. Okay, so in this situation you will go inguinal lymph node dissection. Again, it will be either ipsilateral or bilateral depending upon the site of the lesion. Okay, if the lesion is lateral, that means more than 1 centimeter from the midline, then you will do ipsilateral. But if the lesion is within the 1 centimeter of the midline, you will go for bilateral. Okay. Sometimes they give you that the lymph node dissection is done and the ipsilateral shows the lymph node positive. Then you have to do bilateral. If you have done it unilateral and if it is positive, in that particular case, you have to do bilateral also. Okay. So this is what is the flowchart for the biopsy proven vulvar scale carcinoma. So this flowchart is clear to you? Shall we go ahead?
Yes, sir.
Yeah.
Yes, sir.
Yeah. So now, up till now, what we have seen, suspicious lesion. Okay. Then we have seen about the biopsy. Then we have seen about the proven lesion. Okay. Now we will see from here onwards different types of malignancy. What are the different types of histopathological types of malignancy you get in the vulva? The most common is a squamous cell carcinoma. So what is the purpose of imaging here? The purpose is same, assess the groin and pelvic lymph nodes and detect locoregional or distant spread and pre-surgical staging and planning. That is what is the, so what are the imaging recommendation when you have a vulval malignancy? Okay, so there are different types of malignancy in the vulva. The most common is squamous cell carcinoma. The purpose of imaging is to know whether the groin lymph nodes are involved or the pelvic lymph nodes are involved or not. Is there any spread? And what is the pre-surgical staging? That is what we would like to know. And that is why what the techniques which are available, one, you can do ultrasound of the groin. Second, CT, chest, abdomen, pelvis, or MRI pelvis can be done. Then PET CT can also be done. Okay. Then additionally, you can do the fine needle aspiration or core biopsy. Then you can also do the CT scan preferred in patients unfit for radical treatment. Okay. Then another type of malignancy you get in vulva is a vulval melanoma. This again melanoma they can ask you. In fact, this question has been asked in the past on the vulval melanoma. Okay. The purpose of imaging here is same to know the or assess the local extent and mets, the lymphatic and hematogenous and direct intracranial lesions. Melanoma can go to the brain also. Okay, metastasis can happen in the brain also. So you have to do CT, chest, abdomen, pelvis to identify the systemic spread. Also, either CT or MRI you will do for head. Okay, for brain metastasis in vulval melanoma. Okay, and frequently it presents at a advanced stage. So, okay, and refer to orogenital mucosal melanoma guideline for detailed protocol. So there are specific melanoma guidelines. These guidelines we will refer. Okay. The third type of malignancy is a basal cell carcinoma. Okay. Here the purpose of staging is same. This basal cell carcinoma is relatively better and the excision is the treatment. Here evaluate the nodal or distant spread. No imaging is required unless nodal disease is suspected. Okay. So as such, there is no imaging required and distant mets are extremely rare. So this basal cell carcinoma, it has got a typically what kind of ages you will have? Rolled out ages. So if you get this particular picture of the lesion and they ask you about the histopathology, think of basal cell carcinoma. Okay, and the imaging is generally not required unless you suspect the nodal involvement because mets are rare. Next is a Bartholin's gland carcinoma. Okay, they can ask you about this also. They can give you the location of the lesion, and the here the purpose of imaging is to assess the local invasion and regional or distant spread preoperative staging. The investigations are CT, chest, abdomen, pelvis, MRI pelvis you can do, and MRI pelvis for local. These are the investigations. Okay. Then lesions are deep-seated and often unsuitable for sentinel node biopsy. That is why you need to do CT and MRI of the pelvis. Then Paget's disease we have seen. Paget's disease has got a high risk of recurrence. So the purpose of imaging here is evaluate the local stromal invasion, rule out secondary malignancy of skin appendage, anorectal or urothelial origin. So here also again MRI pelvis, CT chest abdomen pelvis is required. Then cystoscopy, colonoscopy, PET CT. These are the investigations which are required. Then additional notes useful to identify multifocal or metastatic spread, and imaging complements the histologic and clinical assessment. That is why this imaging is required in Paget's disease of vulva. Okay. Now this table shows the pathology and what is the precursor lesion. Okay, we have seen that there is a pre-malignant lesion which will lead to malignancy in the vulva. Okay, so they may ask you, so the pre-malignant condition for this particular vulval malignancy or vulval cancer. If when you have a vulvar squamous cell carcinoma, it may be, we have seen VIN, which can be usual VIN, which is HPV related, or it can be differentiated vulval intraepithelial neoplasia, DVI. Okay, that is vulval dermatosis, LS and LP related. Second, there can be Bartholin's gland carcinoma, which is a squamous cell carcinoma or adenocarcinoma or transitional cell carcinoma. So these are the different types of carcinoma you get in Bartholin's gland, and usual VIN for HPV related squamous cell carcinoma. This is what is the precursor here. Okay, usual VIN. Here there are LS and LP also here involved along with the usual. Here it is a usual VIN is a pre-malignant lesion. Now next is a melanoma. For melanoma, vulval acanthosis with altered differentiation, VAD, VAAD. Okay, VAAD. That is vulval acanthosis with altered differentiation. This is what is the pre-malignant condition. For invasive Paget's disease, that is an adenocarcinoma. Vulval Paget's disease, VPD, that is adenocarcinoma in situ, that is the pre-malignant condition. Basal cell carcinoma, good prognosis. It does not have as such directly the you get this lesion. Okay. Now, vulval squamous cell carcinoma, there is no fixed regimen as such, and follow-up is individualized. This is about the follow-up. Follow-up is individualized based on the risk and background pathology. For usual VIN, unifocal VIN, up to the 5 years we have discussed. Okay, but if it is a multifocal, then the lifetime requires long-term or lifelong surveillance. Okay, for Paget's disease, again, lifelong specialist follow-up is required due to high risk recurrence risk. Basal cell carcinoma, limited follow-up if margins are clear. That is why this basal cell carcinoma has got a good prognosis. Mets are rare, the excision is the treatment, and if the margins are clear, the follow-up is also limited. Melanoma, follow-up along mucosal melanoma protocol is there. There is a melanoma MDT also, that case needs to be discussed there, and the follow-up also as per the protocol of the melanoma. Now let us see about the follow-up after vulval malignancies. Okay, vulval squamous cell carcinoma. Few things we have already seen. There is no as such randomized control study giving the data to us. Based on the whatever the information is available on the expert consensus only. Overall recurrence rate is around 22%, and differentiated VIN and differentiated VIN plus LS and LP, that has got a higher risk. 4.3 is a odds ratio. So there can be only differentiated VIN or the differentiated VIN which has developed after LS and LP, that has got a higher odds ratio. Then you have a usual VIN related squamous cell carcinoma that has got a low odds ratio. You don't remember all these figure, but just remember which one is highest. So highest will be differentiated VIN, which is superimposed on LS and LP. Okay. Then what is the timing of recurrence? It can recurrence can be late, and lifelong follow-up is justified. For unifocal disease, discharge the case after 5 years. Okay. Vulval and groin examination, assess and physical and psychological sequelae. Frequency will be 3 to 6 months every 2 years for first 2 years, then 12 monthly for 5 years. That is what is the follow-up. Imaging will be at 3 months you will do the CT scan to document remission, and 3 monthly groin ultrasound for 2 years after negative lymph node central lymph node biopsy. Okay. Spatial groups, multifocal or recurrent disease, then more frequent or long-term follow-up is required. Discharge advice, patient should report newly lesions and ensure direct access. So when there is any new development of the lesion, directly referral is recommended. Okay. If you have a basal cell carcinoma, we have just seen it has got a good prognosis. So the follow-up is need is very minimal as the recurrence is rare. If excised completely, single review at 3 months post-surgery to check wound healing and local recurrence. But if it is associated with Gorlin syndrome, then the long-term follow-up in the dermatology is required. Vulval Paget's disease has got a high risk of recurrence, local recurrence, and invasive transformation. The risk is very high, and here also the follow-up is lifelong. In specialist vulval cancer clinic. Now, vulval malignant melanoma. This also we have seen. This is the second most common vulval malignancy. Around 7 to 10% of all vulval cancers. It has got a high relapse rate, around 50%, and it will depend upon the breast thickness, that is the depth of invasion. 5-year survival is around 80%. Tumor size is the most important prognostic factor for local recurrence. So melanoma, what is the important factor is the tumor size. Then lymphadenectomy, adjuvant chemotherapy, margin width, they are not significantly linked to the survival, but the tumor size is the most important for the local recurrence and survival also. Distant recurrence is related to AJCC stage, that is thickness, ulceration, nodal or distant spread. Younger has got a better survival. Multidisciplinary management cases should be discussed both in gynecology as well as melanoma MDT. This also I have discussed. So this case should, whenever there is a melanoma, it has to be discussed in the gynecology as well as melanoma MDT with coordinated pathway. And slides are important from examination point of view. So suspicious vulval lesions. Okay, whatever we have discussed before, what is the general risk and referral? In a study of referred with vulval symptoms, there is around 13% chance of this vulval lesion to be malignant. Higher risk of invasion is noted when the lesion is symptomatic, that is associated with pain and bleeding. There is a high chance of invasion. Generalized vulval irritation without visible lesion is unlikely to be a cancer. So if there is only irritation, but there is no visible lesion, then it is unlikely to be a cancer. While there is a symptom and lesion, there is a 13% chance of malignancy. Highly suspicious clinical features such as fungating lesion, palpable groin nodes, you need to do the urgent referral to cancer center without waiting for biopsy. Then punch biopsy may be inadequate for large or deep lesions, and delay for biopsy is not advised. Melanoma, we have already seen the rare malignancy of the vulva. It may or may not be pigmented. It can arise in the background of melanocytic dysplasia. Symptoms will be change in the pigmentation, itching, bleeding, or maybe asymptomatic also. It will appear as irregular pigmented or non-pigmented macule, papule, patch, or nodule. It may have ulceration, sometimes first detected due to groin lymph node enlargement. So there may be late diagnosis, and the presentation may be with the groin lymph node involvement. Okay. Basal cell carcinoma, better prognosis, presents as a discrete vulval lesion with a raised rolled edges. So this particular buzzword you remember, and if you get this, then most likely it is going to be basal cell carcinoma. There is no background dermatosis or usual behind in these particular cases. Bartholin's gland carcinoma, it is rare. Presents as a painful vulval or lower vaginal mass near the Bartholin's gland. It is often misdiagnosed as a Bartholin's cyst or abscess. Should be suspected or excluded if the woman is more than 40 years and presenting with Bartholin's abscess. Okay. Incorrect excision or marsupialization can delay diagnosis and complicate further treatment. Now, what is the role of biopsy in suspected vulval lesions? You have a lesion which is suspicious, then what type of biopsy is to be taken? That is given in this particular slide. So the type of biopsy recommended is an incisional biopsy. Either punch or wedge biopsy is preferred and should include the age of the lesion, showing the transition from normal to abnormal tissue. Avoid the central ulcer. It may be non-diagnostic. Adequate depth needed to differentiate between superficially invasive or more than 1 millimeter invasion, as it guides the management. Excision biopsy generally avoided since it may limit the conservative treatment options such as wide local excision plus sentinel lymph node biopsy. So if you excise, then you don't have this particular option, because we are when we diagnose the cancer first, we are able to go up to R, means our aim is a R0 resection, that is adequately grossly as well as microscopically adequate margin should be there. Okay, that is what first you do the incision biopsy, diagnose, and then go for proper excision, which will have R0 resection. Okay, then small lesions can heal and make the site difficult during the definitive surgery. So when you have done the excision biopsy, and if it is a small lesion, it will heal. And what is the what was the site, that identification will be difficult. Except you can go for excision biopsy only in elderly or frail patients, in a small symptomatic lesion, it may be excised under local anesthesia or palliation or planning. Excision to be done by the gynecologist, oncologist, but generally it is not a preferred. Excision is not preferred, and why it is not preferred, that also we have discussed. Then what are the recommendations for other vulval, rare vulval malignancies? Bartholin's gland carcinoma. Patients often present advanced age. Multimodal treatment is generally required. So full body imaging with CT, chest, abdomen, and pelvis should be performed before surgery to assess the disease extent and plan the management. So adequate investigation is most important when you have Bartholin's gland carcinoma. Vulval patches disease also we have discussed. At diagnosis, it is important to exclude the coexisting malignancy in other organs such as breast, gynecological, urological, or colorectal tracts through appropriate investigation. Surgical treatment should aim to remove all visible disease with macroscopically clear margins. Microscopic margin involvement is common. However, re-excision may not always provide benefit. So you can go ahead with the re-excision, but still re-excision may not benefit always. Okay. So topical imiquimod mode may be useful in non-invasive disease and can reduce the need for the surgery. Radiotherapy or photodynamic therapy have been used in some cases, but evidence supporting their effectiveness is very limited, so they should be used cautiously. So vulval patches disease mainly R0 resection. You have to go for surgical treatment, remove all visible disease, both macroscopically and macroscopically clean. Margin should be clear. Okay, and if there is a microscopic involvement, then you go for re-excision, but it may not always benefit. Okay, that is what you should remember. Then vulval malignant melanoma, it is the second most vulval malignancy after squamous cell carcinoma. Okay, around 70-10% of all vulval cancers. In international vulvar cancer study, the incidence was around 2.4% for this vulval malignant melanoma. Again, this particular thing is known for high recurrence rate or the relapse rate around 50% with mean follow-up of 44.1 months. Mean overall survival is 5-year survival is 80%. Tumor size was the only significant factor in predicting the local recurrence. This also we have seen tumor size is the most important. While surgical margin width, lymphadenectomy, adjuvant therapy, they have not shown any impact on the survival or the recurrence. Okay. Then distant recurrence correlated with the AGCC staging. This also we have discussed. Okay. Now management approach. The case should be discussed both in gynecological oncology MDT and melanoma MDT for coordinated management. Then surgical treatment, aim for R0 resection and microscopically clear margin more than 1 millimeter. More radical surgery does not improve the outcomes. If margins are involved, then salvage therapy is recommended wherever it is feasible. If not possible, then go for watchful waiting, adjuvant radiotherapy or systemic therapy. Okay. Now, how the lymph nodes are managed. Okay. Inguinofemoral lymphadenectomy does not improve the survival. Sentinel lymph node detection may guide the treatment planning. This also we have discussed actually. So now, let's see about the FIGO staging. Okay, so they may ask you the question from this. They will give you the clinical scenario and the investigation, and they will ask you to identify the stage of the disease, and you will be having multiple options, 10 to 12 options. Okay, now what is there in stage 1? In stage 1, the tumor which is confined to the vulva, it may be stage 1A or 1B. Okay, in 1A, size is less than or equal to 2 centimeter. Remember here, size equal to 2 centimeter is 1A. Okay, and stromal invasion is less than 1 millimeter or equal to 1 millimeter. Okay, so these cutoffs you should remember. So 2 is included here, 1 is included. So if there is a depth of invasion is 1 millimeter, means it is 1A. If it is more than 1, then it is 1B. Okay, tumor size more than 2 centimeter or stromal invasion more than 1 millimeter. Okay, then it is 1B. Okay, here it is tumor size should also be less than 2 centimeter or equal to 2 centimeter, and stromal invasion should be less than or equal to 1 millimeter. While here either the lesion is more than 2 centimeter or the stromal. So even if it is less than 2 centimeter, but the stromal invasion is more than 1 millimeter, then it becomes 1B. Okay. Now stage 2. In stage 2, tumor of any size with extension to the lower 1/3 of the urethra, lower 1/3 of the vagina, lower 1/3 of the anus with negative nodes. So in up to stage 2, there are no lymph nodes involved. In stage 3, there is a lymph node involvement. Okay. So upper genital organs are also involved and the lymph nodes are also involved. Okay. So in stage 3, you have tumor of any size with extension to the upper part of the adjacent perineal structures or with number of non-fixed, with any number of non-fixed and non-ulcerated lymph nodes. Okay. So in stage 3A, the tumor of any size with disease extension to the upper 2/3 of the urethra, upper 2/3 of the vagina, bladder mucosa, rectal mucosa, or regional lymph node mates should be less than 5 millimeter. So in the all actually 3A, 3B, 3C, there is a nodal involvement. So here either there is a nodal involvement which is less than 5 millimeter, or there is a upper perineal structures which are involved. That is upper 2/3 of the vagina, bladder, or the rectal mucosa. Okay. In stage 3B, regional lymph nodes are involved, but the size is more than 5 millimeter. Here, stage 3C, regional lymph node mates with extracapsular spread. Okay. So in stage 3, you will get the upper perineal structure involvement in stage 3A, or there is a lymphadenopathy which is less than 5 millimeter, more than 5 millimeter, or extracapsular spread. And accordingly, we will label is A, B, and C. Okay. In stage 4, tumor of any size which is fixed to the bone or fixed ulcerated lymph node mates or distant mates. Okay. Stage 4A, the disease is fixed to the pelvic bone or fixed or ulcerated regional lymph node mates. Okay. In 4A, you have disease which is fixed to the pelvic bone or fixed or ulcerated regional lymph nodes. Well, stage 4B is a distant metastasis. Okay. So this is what is the FIGO staging. The FIGO staging for all malignancies, that is cancer cervix, CA uterus, then ovarian malignancy, vulva, these all you should remember. They can ask you, the questions are asked about the specific stage. They will ask you to identify what is the stage of the disease. They will give you the scenario and the investigations. Okay. Now, what are the important highlights about this particular classification, FIGO classification? Okay, so the depth of invasion. Depth of invasion is measured from the basement membrane of the deepest adjacent dysplastic tumor-free retirages or the nearest dysplastic retipeg to the deepest point of invasion. Lymph node positivity. Classification now aligns with the cervical cancer staging because it divides into macromates and the micromates. Okay, we have seen less than 5 millimeter involvement or more than 5 millimeter involvement, etc. Okay, individual tumor cells are not counted as a lymph node metastasis. Imaging, cross-sectional imaging such as CT, MRI, PET findings are incorporated into the vulvar cancer staging similar to cervical cancer. Acceptability, the updated staging system applies to all morphological types of or vulval cancer, not just squamous cell carcinoma. Exception is the vulvar melanoma. Okay, so except this vulval melanoma, this classification is applicable. HPV status documentation, you have to document the HPV status. HPV associated versus HPV independent is strongly recommended, and this is determined by the P16 block type immunoreactivity and or positive molecular HPV testing. That also we have seen in the last session. Okay. Now let us see about the lymph node management in vulval cancer. Okay. So if it is a stage 1A disease, that means depth of invasion is equal to or less than 1 millimeter. Then there is no need for the lymph node assessment. Okay. Risk of nodal spread is less than 1%. So surgery is limited to the local excision only. Okay. Now, if it is a unilateral lesion, more than 1 millimeter depth, in that particular case, sentinel lymph node biopsy of ipsilateral groin is indicated. So you have unilateral, unifocal, but the lesion is lateral. Lateral means 1 centimeter away from the midline, but the depth of this actually we have seen in the flow chart also. Okay, so you have a lateral lesion. If this is the midline and the lesion is more than 1 centimeter, we label this as a lateral lesion. But it is a unifocal, then you go for ipsilateral sentinel lymph node biopsy. Okay, so lesion more than 1 centimeter from the midline, sentinel lymph node technique is validated. Okay, dual dye plus radioisotope. If sentinel lymph node is positive, then complete ipsilateral inguinofemoral lymphadenectomy or adjuvant radiotherapy. Okay. Then if it is a midline or near the midline and the depth of invasion is more than 1 millimeter, then bilateral sentinel lymph node biopsy and bilateral groin drainage risk is there. If sentinel lymph node biopsy are positive on one or both sides, then you have to do the bilateral lymphadenectomy. Okay, or adjuvant radiotherapy is another option. If the disease is multifocal or large, more than 4 centimeter lesion, then bilateral inguinofemoral lymphadenectomy. For more than 4 centimeter, directly go for bilateral inguinofemoral lymphadenectomy. There is no role for the biopsy, sentinel lymph node biopsy. Okay, so sentinel lymph node biopsy is mainly when the size of the region is less than 4 centimeter. That already we have seen the criteria for the sentinel lymph node biopsy. Okay, now what is the recommended procedure uh, and nodal procedure, and what is the clinical situation that we will see. So if you have a clinically palpable or radiologically enlarged groin nodes, then the therapeutic inguinofemoral lymphadenectomy is indicated, unilateral or bilateral based on the disease laterality. Okay, midline disease, you will go for bilateral. If it is a lateral, you go for unilateral, but if it is positive, you will do bilateral. Okay, so if you have a clinically palpable or radiologically confirmed groin nodes, you have to go for inguinofemoral lymphadenectomy, that is sure. And this sentinel lymph node biopsy is contraindicated. Okay, then sentinel lymph node not detected intraoperatively. Suppose you are performing sentinel lymph node, but if they are not detected, then go for a full lymphadenectomy on that side. So you will do the ipsilateral lymphadenectomy if there are no detection of the sentinel lymph node. Okay, suppose your criteria for the sentinel lymph node are satisfied, you are doing the sentinel lymph node dissection, but you are not getting the lymph nodes, then you will go for a full lymphadenectomy. Okay, avoid leaving groin unstaged if the SLN mapping fails. So you will not leave the groin unstaged at all. Okay, then if your sentinel lymph node is positive, you will again go for bilateral either micromets or macromets, and then you will go for a bilateral lymphadenectomy plus adjuvant radiotherapy to the groin. It depends upon the nodal burden and patient fitness. Adjuvant radiotherapy often preferred to avoid morbidity of second surgery. Okay, if there is a extra capsular spread in nodes, then adjuvant groin and pelvic radiotherapy is required. Improves regional control and survival outcomes. Recurrent disease in previously dissected groin, re-irradiation or palliative management. Surgical re-exploration carries high morbidity and decision individualized. So if there is a sentinel node biopsy, it should be performed only in specialized oncological centers with validated protocols and nuclear medicine support. False negative rate is low, less than 5% when performed correctly in early unifocal and lateral tumors. Okay, so this is very important. This is it has got a low false positive rate, false negative rate, especially if the lesion is early unifocal and lateral tumor. Postoperative morbidity like lymphedema wound breakdown is significantly lower in sentinel lymph node biopsy compared to full lymphadenectomy. Groin recurrence risk is less if the negative sentinel lymph node biopsy around 2 to 3%. Then adjuvant radiotherapy is indicated for positive nodes, extracapsular extension, and multiple involved nodes. So this is what is the stage wise treatment for vulval carcinoma. If you have a stage 1A, wide local excision, this is also very frequently asked. They'll give you the stage and they'll ask you these options. Multiple options will be given. Lymph node dissection is not required. Adjuvant treatment is not required. So only wide local excision is required. You have 1B, and 1B criteria are more than 1 millimeter depth of invasion or lesion size more than 2 centimeter. Okay, what you have to do, radical local excision or partial vulvectomy. You will do the sentinel lymph node biopsy and further lymphadenectomy depending upon the involvement. Okay, stage 2. In stage 2, is there a nodal involvement? There is no nodal involvement in stage 2, but what is there in stage 2 is the lower perineal structures are involved. So you will go for radical excision plus minus resection of the urethra, vagina, and anus. you will do mainly lymphadenectomy. Here, actually, there is a very less role of sentinel node. You will go for lymphadenectomy, and plus you require neoadjuvant or adjuvant CCRT if margins are limited. Okay. Then stage 3. Here, definitely you have a involvement of the upper perineal structures as well as lymph node involvement is there. So you will go for radical excision plus lymphadenectomy is mandatory. Post-operative radiotherapy for positive nodes. Stage 4. Here, palliative procedures and case-based decisions are taken. Radiotherapy, divergent procedures, and symptomatic relief. These are the goals. Okay. Now, this is the same thing we will see in the treatment summary. Stage 1, tumor which is confined to the vulva. Stage 1A, we have seen these stages. The treatment of choice is a wide local excision with clear margin, more than 1 to 2 millimeter. Microscopically, it should be free. Then primary closure is usually possible. Reconstructive surgery if large defect or near posterior vulva. Okay. Lymphadenectomy is not required in 1A. Okay. Outcome is excellent. Prognosis is good. Stage 1B. Here, the lesion size is more than 2 centimeter and depth of invasion is more than 1 millimeter. So treatment is a radical wide local excision. Here it was only wide local excision. Here it is a radical wide local excision or partial vulvectomy depending upon the tumor site. Then you have to achieve the microscopic clearance more than 1 millimeter. Reconstruction flaps or graft may be required for large or midline lesions. Lymph node assessment, sentinel lymph node or lymphadenectomy is indicated. Suppose if it is a periclitoral lesion, then you will go for anterior vulvectomy. They have asked this periclitoral lesion also. Once anterior vulvectomy, but there is a risk of sexual dysfunction. So if the lesion is posterior, then go for posterior vulvectomy, but ensure that anal sphincter is preserved. Lesion near the urethra, excise distal 1 to 2 centimeter of the urethra if needed. So this is what is the stage 1B. Okay. Now stage 2. Here there is a involvement of the lower perineal structure. Here you will go for radical vulvectomy with adequate margins and resection of the distal urethra or vagina if involved. If anal margins are involved, consider neoadjuvant chemoradiotherapy, that is CCRT, to shrink the tumor and preserve the continence because the anal margin is involved. So we will try to preserve the sphincter by giving neoadjuvant chemoradiotherapy. In selected cases, temporary colostomy or definitive resection may be required. Goal is R0 resection while minimizing the functional loss. In stage 3, what is that? Nodal involvement is there or upper perineal structures are involved. So primary tumor management is same as in stage 2, that is adequate excision with margins. Then groin, you will do bilateral inguinofemoral lymphadenectomy. Okay. Then adjuvant therapy, postoperative radiotherapy will be required for node positive or extracapsular spread. Recurrence in skin bridge between the primary and node is low. En bloc resection is not routinely required. Stage 4 is an advanced disease. Stage 4A, local invasion to the upper urethra, vagina, bladder, rectum, pelvic bone, etc. Stage 4B is a distant metastasis, including the pelvic bones. So here the treatment approach is radical surgery is rarely appropriate. The main management is a palliative management aimed at symptomatic relief. So debulking or divergent procedures, palliative radiotherapy or chemotherapy, defunctioning stoma may be required. Goal is to improve the quality of life and manage complications. Key surgical considerations: mark margins before the incision to avoid the tissue stretching. Consider Langer's lines for the optimal cosmetic healing, and excise background DVIN or Paget's disease to reduce the recurrence. Recurrence risk often new primary lesions in areas of lichen sclerosis or VIN. So this is what actually we have seen in the flow chart. Here in stage 1A, lesion is less than or equal to 2 centimeter in size. Depth of invasion is less than or equal to 1 millimeter stromal invasion. The nodes are negative. Stage 1B, it is more than 2 centimeter or stromal invasion is more than 1 millimeter. Then depth of invasion is more than 1 millimeter. Nodes are negative. Now you have wide local excision and the radical wide local. Here in stage 1A, you go for wide local excision. In stage 1B, you go for radical local excision. Here, node management is not required in 1A, while sentinel lymph node biopsy or lymphadenectomy will be indicated in 1B. And in margin of depth is only up to superficial subcutic, while the deep fascia up you have to dissect up to the deep fascia. Okay, so we'll see the difference between the wide local excision and radical local excision, that is 1A and 1B. Okay, so wide local excision is to completely remove small minimally invasive disease with safe margins while preserving the anatomy. It is up to the superficial subcutaneous tissue with no involvement of the deep fascia. Aim is more than 1 centimeter gross margin, so that histologically you will get 8 millimeter or more histologically clear margin in wide local excision. Okay, and extent of resection is minimal, preserving as much as normal vulvar skin as possible. While in 1B, you have to go for radical local excision, that is to remove the tumor with wider and deeper margins to ensure the complete clearance of more invasive disease, and it extends to the deep fascia of urogenital diaphragm or perineal membrane to include all subcutaneous tissue. Aim is more than 1 centimeter or more than 8 millimeter histological margin, but deeper and broader resection is required in radical local excision. Okay, and extent of skin resection is wider excision of skin and subcutaneous tissue surrounding the lesion. So that is what is the difference between wide local excision and radical wide local excision. Okay, here anatomical structure, only lesion plus small rim of normal tissue is removed. Here tumor plus entire thickness of the skin, subcutaneous tissue down up to the deep fascia, but without removing the underlying muscle or adjacent organs. Okay, groin node evaluation in 1A it is not required. Here it is required, either SLNB is required or the lymphadenectomy, because risk of METS is around 8% or more. Here it is less than 1%. Okay, functional outcome is good with a wide local excision, minimal distortion, minimal sexual or urinary dysfunction, while there is a higher risk of scarring, sexual dysfunction, wound complications, but oncologically it is necessary. Okay, so practical surgical principles are both aim for R0 section, that is wide local excision plus radical local excision. Margins are at least 8 millimeter histological clearance is required for both. Re-excision is recommended if the margins are involved or less than 8 millimeter. Groin node management differentiates the two. So there is a difference between the groin node management in wide local and in radical local. Okay. So that finishes the malignancy of the vulva. Thank you.